Okay, well, good afternoon, ladies and gentlemen, and welcome to our monthly Senior Fellow Society webinar. First of all, could I take this opportunity to wish you and your families a happy, a healthy, and a safe new year in these unprecedented times, and let us all hope that 2021 will indeed herald a return to some degree of normality. It is my particular pleasure to introduce our distinguished speaker, my friend and colleague at UCL, Professor Sir Michael Marmot. Michael is Director of the Institute of Health Equity at UCL, an advisor to the World Health Organization on social determinants of health. He's internationally recognized as shown by his amazing 18 university honorary doctorates. Michael has led research groups on health inequalities for nearly 50 years and conducted the strategic review of health inequalities in England, which is known as the Marmot Review. He has served as president of the British Medical Association and as president of the World Medical Association. He was a member of the Royal Commission on Environmental Pollution for 6 years. In 2000, he was knighted for services to epidemiology and to the understanding of health inequalities. I think we've all been made aware of the disparity in the health and social consequences of COVID infection, and surely there can be no one better suited to talk on social justice, on health equity and COVID-19 than Michael Marmot. We have, unfortunately, a slight hitch. Despite every attempt, we are unfortunately unable to have a visual of Michael. Fortunately, you'll be hearing him speak, and fortunately, we have the slides to show. But despite all attempts, I'm afraid that you will not be able to see Michael. And this is unfortunate, but nevertheless, an indication of some technological problems which seem to be beyond our capabilities of solving. Now, before we start, could I say that we will have a Q&A session at the end, and any questions that individuals wish to place, could they please put them on the chat line, and then Jane Roberts and I at the end will coordinate the questions. So, Michael, I'm sorry that we can't actually see you, but I'm sure we'll be able to benefit from your words of wisdom. So, Michael, perhaps you could take over. Thank you.
Thank you. I've often thought that my data look better than I do. So I'd like to think you get the better part of it. You can't see me, but you can see my data, which are far more compelling. I've called the talk, I changed the name of it to Build Back Fairer, because that was the title of the report that I published on the 15th of December, 2020. But I'm going to start in February last year, because we published this report, the Build Back Fairer report, in a way because we published a report in February that said what was happening to health in England at the beginning of the year before the pandemic hit us. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. I presume the people listening to me now mainly are in the business of treating people when they get sick. I'm concerned with the conditions that make people sick. And the report that we published in February, on the 25th of February 2020, Health Equity in England, the Marmot Review, 10 years on. As Irving said in the introduction, in 2010, I had been commissioned by the then government to do a review, a strategic review of health inequalities that was published as Fair Society, Healthy Lives, the Marmot Review. We weren't asked by government to do this 10-year follow-up. We were funded by the Health Foundation. But I looked back at what had happened in the last 10 years. And here's my simple summary. We've lost a decade, and it shows. What do I mean? Well, if you look at life expectancy in England, for women and for men, life expectancy was increasing about 1 year every 4 years. I've taken this back to 1980. If I took it all the way back to 1890, you'd see the same. Life expectancy increasing about 1 year every 4 years. Dramatic, very welcome. And then something happened in 2010, and the rate of increase slowed dramatically. What happened in 2010? Well, we got a new government. They were a bit sensitive. You can't surely be alleging that it was anything we did that could have led to this slowdown in improvement. Well, it's possible, and it's something we should look at. One question that people raised was, maybe we've reached peak life expectancy. It's got to slow sometime. So we looked at what was happening in other countries. Annual life expectancy improvement in weeks 2011 to 17. And here we are: Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, the UK. We had the slowest rate of improvement in life expectancy of any rich country except Iceland and the US, which was the worst. So no, we had not reached peak life expectancy. The slowdown in the UK and in England in particular was more marked than in any other rich country except Iceland and the US. I've been emphasizing the social gradient in health for a very long time. So these are small areas of the country classified by level of deprivation, and we've classified them into deciles, 10% of the distribution. And people commonly think the problem with health inequalities is poor health for the poor. And the poor do have poor health. But that's not the real drama in these data. The drama is the gradient. It's a graded phenomenon. The less the deprivation, the longer the life expectancy. And it runs all the way from top to bottom for women and for men. The gap between the bottom decile and the top decile was 9.5 years for men, 7.7 years for women. And that gap has been increasing over the last 10 years. So the inequalities are getting steeper. And if we look by region, this is women, a similar picture for men. In the least deprived 10%, these are different regions of the country, there's not much regional variation. And there's a modest improvement in life expectancy for the least deprived 10% in every region. Now, if we look at the most deprived 10%, there's a huge regional variation. Another way of saying this is, if you're in the least deprived 10%, it doesn't matter where in the country you live. Health's okay, and it's been improving a bit. If you're in the most deprived 10%, it matters enormously where you live. The disadvantage of living in the Northeast and the Northwest is seen particularly the more deprived you are. So for the most deprived 10% of women, it was improving, life expectancy was improving in London and actually going down in every other region outside London. Wow. So just think, this is where we were before the pandemic struck. Health had stopped improving. Inequalities had been getting bigger. And life expectancy for the poorest people outside London was going down. And it's not just length of life, but quality of life. Disability-free life expectancy. The top graph is life expectancy, and the bottom one is disability-free life expectancy. The gradient is steeper. We put here state pension age, plans to make it a bit older, 68, and you can see that maybe 70% of people do not have disability-free life expectancy as long as 68. In my 2010 Marmot review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Everyone should have at least the minimum income necessary for a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. That was the cover of the 2010 report. We didn't focus on the last one, on lifestyle, in the 2020, the 10 years on review, for this reason. Suppose people followed the healthy eating guide, the NHS Eat Well guide, for people in the bottom 10% of household income. They would have to spend 74% of income on food. If you think that poor people are somehow disagreeable, awkward, don't listen to advice, that's why they don't eat healthily, or as I've heard a succession of upper class women say, I could live on that, they just don't know how to cook. Well, the fact is they can't afford it. They would have to spend 74% of their income on food if they were to follow the healthy eating guide. So the government, the Conservative-led coalition government in 2010, had as its central mission austerity, rolling back of the state, and they did it. In 2009-10, 42% of public expenditure, 42% of GDP went as public expenditure, and that 42% became 35% by 2018-19. So there was a significant rolling back of the state, less public expenditure, and it was done in a most regressive way. This is spending by local authorities per person, by the level of deprivation. So in the least deprived 20% of areas, look at the grey bars, the total local authority spending per person was reduced by 16%. And then the more deprived the area, the greater the reduction in spending. So in the most deprived 20%, the spending per person went down by 32%. I talk about proportionate universalism, universalist policies with effort proportionate to need. This is the reverse of that. The more deprived the area, the greater the need, the greater the need, the greater the reduction in spending. I showed this slide to an economist working for the World Health Organization. She said, "You're making this up. I've never seen anything quite as neatly regressive as this." Could this have had an impact on worsening health and increased inequalities? Yeah, I think it could. What do you think local government was doing? It was spending on services. Look at adult social care spending per person. Went down by about 3% in the least deprived areas, went down by 16% in the most deprived areas. And this economic policy of government didn't work. They told us that austerity was necessary to get economic growth. They boasted that Britain was the envy of the world, that our economic policies are working and everybody's looking at Britain saying how brilliant we are. Well, it wasn't true. This is wage growth in the UK, 2007 to 2018. It was negative. Only Mexico and Greece looked worse of the rich countries, Portugal and Italy about the same, and every other country had positive wage growth. Our policies led to people on wages being worse off over that whole period. So we were told we had to put up with austerity to get the economy working, and it wasn't true. The economy wasn't working, not for people who are employed. Young people, children living in poverty, before after housing costs. So in 2010-11, poverty is defined as less than 60% median income. It's a relative measure. And that's standard, the relative measure. I'm saying this, you'll hear in a moment why I'm saying this. So about 18% of children were in poverty in 2010-11. After housing costs, that 18% becomes more like 27%. And over the decade, 27% went up to 30%. These are government figures. Now, I try not to be party political, but I heard the Prime Minister, when he was asked about this in Parliament in 2020, say that they'd taken, he made up some funny number of how many fewer children were in poverty. And I thought, I'm looking at the figures, government figures. It's not true. Child poverty went up. And he was questioned, and he came back to Parliament and repeated the lie. I thought when you lied to Parliament, you were supposed to apologize and correct it. You just doubled down on the lie. Child poverty went up. You can say it went up for a whole variety of reasons. What you can't say, as they keep repeating, is that it went down because of their wonderful policies. It didn't, went up, and that will damage children. And if we look at family type, a lone parent not working, 62% of children were in poverty if they were in a family with a lone parent not working, and that went up to 70% of children of a lone parent not working. Work was supposed to be the way out of poverty. So look, a lone parent in full-time work, 18% of children were in poverty, and that went up to 30%. Work was not the way out of poverty. A majority of people in poverty are in households where at least one adult is working. And these are the reforms the Chancellor made in May 2015 by deciles of income. So let's look at working age families with children. If you were in the bottom 10% of income, as a result of the changes made to the tax and benefit system by the Chancellor, your income would go down by 15%. If you were in the second bottom decile, it would go down by 12%, then by 9%. And the richer you were, the less the reduction. I showed a version of this slide to a former government minister that I met. And I said, your government's policy was to make poor people poorer. And he looked uncomfortable. He said, well, maybe it wasn't our explicit policy. What do you mean, not your explicit policy? They're very clever people in Her Majesty's Treasury. They must have told the Chancellor that this was the effect of his policies, and he did it anyway. Could that damage health? Yeah, I think it could. And more families are spending more than 1/3 of their income on housing. And of course, the more deprived the area, the higher the proportion of families that are spending more than 1/3 of their income on housing. When you're spending more than 1/3 of your income on housing, it means you're not spending on food. If you're going to spend 1/3 of your income on housing and 74% on eating healthily, who's going to buy children new shoes? And the number of households in temporary accommodation increased dramatically. The estimated number of people sleeping rough in England tripled since the publication of the Marmot Review in 2010. We have a housing crisis. And services for young people, not preschool, but teenagers, young people, closed. Local authorities had to stop spending money, so they closed down these services. And guess what happened? After a small dip, violence increased the most for those in more deprived areas. So these are rates of violence, and you can see least deprived, most deprived, it went up dramatically. You can't stop spending on these valuable services and expect nothing to happen. You damage early childhood, you get more antisocial behavior from young people. And we were very concerned about the environmental side as well. PM10, air pollution, in the most deprived quintile, in the least deprived, in London, Liverpool, Birmingham, Bristol, Leeds, Sheffield. The more deprived the area, the higher the exposure to air pollution. And we very much wanted to bring the social inequalities agenda and the climate crisis together. So, for example, we said, ensure 100% of new housing is carbon neutral by 2030, and aim for net zero greenhouse gas emissions by 2030. That was in February. And then, of course, the pandemic crashed upon us. And my concern was that what we said, our diagnosis of what had gone wrong over the last 10 years, would get forgotten with the pandemic. And the challenge was not just to document what the pandemic did to inequalities, but what happens when eventually we emerge from it. And that's why I called my new report, Build Back Fairer, not just Build Back Better. We do not want to go back to the status quo, to where we were before the pandemic hit. When people said that the pandemic will be the great leveler, I thought, never. This is mortality rates from all causes by deprivation. That's the gradient I showed you before. And here's the gradient for mortality from COVID-19. It's almost exactly the same as the social gradient from all causes or from non-COVID deaths. That's males and females. And the fact that the gradient is so similar for mortality from COVID-19 to mortality from all causes means that the causes of inequalities in COVID-19 overlap to a considerable degree with the causes of inequalities in health more generally. The kind of things that I've been talking about in those 5 domains. Now, there is some relative excess in the bottom 3 deciles for COVID-19. You can't quite see it from this graph, which we think is related to employment in frontline occupations, being exposed to the virus and living in overcrowded, possibly multi-generational households. One thing that was amplified by the pandemic were the inequalities according to ethnic group. Black African, astonishingly high, this is women and men, astonishingly high mortality from COVID-19. And this is what it's like after adjusting for geography, which is largely deprivation, and for other socioeconomic measures. You can see that most of the excess in women, Black African, and more than half the excess in men who are Black African can be attributed to where people live, deprivation, and other socioeconomic characteristics. In Black African and Black Caribbean, prior health status does not contribute to the excess. So many of us, myself included, thought it did, but that's not what the data show. For Bangladeshi, though, prior health status does make a contribution to explaining the excess, and similarly in Pakistani. So much of the Black Asian minority ethnic group excess can be attributed to deprivation or other socioeconomic characteristics. And in the case of Bangladeshi and Pakistani people, prior health status contributes. And as you probably know by now, it's difficult to make comparisons of COVID-19 mortality across countries because of different ways causes of death are assigned. So one way people have done it is to look at excess mortality. In other words, look at how many deaths would have been predicted in 2020 based on the previous 5 years, how many occurred, and then get relative excess. And the excess was higher in England than in Scotland, and higher than Wales, higher than Northern Ireland. And the excess mortality was higher in England than in any other of these European countries. We look across at the US and see that the president, the soon-to-be ex-president, although he won't admit it, opted out of trying to control the pandemic. And it was a disaster. The excess mortality in the UK was higher than it was in the United States. And just to remind you, our slowdown in life expectancy improvement was the worst of any country except Iceland and the US. So I asked myself, what's the link between the state of health, which was less than desirable, slowdown in life expectancy, increase in inequalities, health getting worse for the most deprived people outside London? What was the link between that situation in February and our disastrous management of the pandemic? And I think the link could work in 4 ways: poor governance and political culture in the decade from 2010. If you wanted poor governance and political culture, just think what Britain looked like after the Brexit referendum. Who was thinking about anything of any importance other than how we could damage the economy, known as Brexit? Poor governance and political culture. And I've already told you that, shown you the rolling back of the state that was done in a regressive way. I don't need to amplify what's gone on in poor governance during the pandemic. Social and economic inequalities were increasing. I've shown you the inequalities in health more generally and the inequalities in COVID-19. Reduction in spending on public services. We were ill prepared. And then when we decided we needed to spend, in having stripped public health of funding by £800 million, having cut funding to Public Health England by 40% since 2012, what did we do when we needed to set up a testing and tracing system? We gave it to an ill-equipped, ill-qualified private corporation to spend a lot of money and failed to deliver an effective test, trace, and isolate system. And England was unhealthy coming into the pandemic. Then we look at what happened during the pandemic. Education. Teachers were surveyed in the least deprived areas and the most deprived areas. In the least deprived areas, teachers said that about 3% said their pupils were not behind at all. About a quarter said they are 1 month behind. A third said they were 2 months behind. Now, in the most deprived areas, more than 10% said 6 months or more behind. 20% said 5 months or more behind. So what you see is this spreading out. The lockdown led to increase in the educational divide. Food insecurity. 3 or more children, pre-COVID-19, March to August, huge increase in food insecurity. Young females particularly had higher rates of unhappiness or depression. 16 to 34-year-olds, 35 to 64-year-olds. Some increase in males, but more striking in females. Weekly number of calls for service for domestic incidents, 2019, 2020. Lockdown didn't serve some women very well because of domestic incidents, domestic abuse. And unemployment was mitigated by the furlough scheme, but it's a problem waiting to happen. And even so, it's young people who are most effective, had the highest unemployment cumulative growth at 16 to 24-year-olds. And unemployment increased in every English region between July-September 2019 and July-September 2020. So you can see unemployment was already high in the Northeast and increased more. It was pretty high in London, increased more. West Midlands, East Midlands, in every region. And low-income workers were most likely to be in shuttered sectors. So those of us who could work from home, higher income, were much less likely to be in shuttered sectors. If we're still working, we still get paid. If you're in a shuttered sector, you don't get paid. With the furlough scheme, you get up to 80% of your income. But if you were in the bottom decile, you were probably below the poverty line anyway. And now you're only getting 80% of it. Real hardship. And if you're not in a shutdown sector, you had to go out to work and probably in a frontline industry. So percent paid below the national minimum wage by region in England, 2010, 2020, is rising considerably, not furloughed. You can see that huge increases in the percent of people paid below the national minimum wage. And the percent who reported their finances had been negatively affected as a result of COVID-19 containment. Single adults with non-dependent children, and then couples with dependent children, 40%. Their finances had been negatively affected as a result of COVID-19. So what do we do? I said with our 10 years on report, published in February, that health is a measure of societal success. If health stopped improving, society stopped improving. If inequalities in health were increasing, inequalities in society were increasing. Now, in the executive summary of my Build Back Fairer report, we made a series of specific recommendations. But remind you what I said in trying to think through the link between our poor health status at the beginning of 2020 and our poor management of the pandemic. I said 4 reasons: poor governance and political culture, social and economic inequalities, the reduction in spending on public services, and that we were unhealthy. We need to pay attention to all of these. And I would argue we need to put a fair distribution of health and well-being at the heart of all government policy. We made a whole series of specific recommendations related to the 5 domains that I went through from my 2010 review. But this is at the heart of it. If we are to build back fairer, we have to put a fair distribution of health and well-being at the heart of all government policy. Where might I have got this from? A well-being approach can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. From Nobel Prize-winning economist and philosopher Amartya Sen, possibly, but no, I got it from the New Zealand Ministry of Finance in 2019. New Zealand can do it. Why can't we? Put a well-being approach at the heart of government strategy, enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Thank you. And now if I knew how to stop sharing my screen, I'd do it.
Well, thank you very much, Michael. I'm sorry we can't actually see you as well as hear you, but I think everybody will agree that we've been fortunate in having an outstanding, thought-provoking talk and providing us with a lot of unfortunate truths. We're okay now, Michael, if you're okay to answer a few questions. I have no doubt we will have some because your talk was really so thought-provoking. So could I ask if there are any specific questions that anybody would like to ask? I can't actually see any on my chat screen at the moment, but Jane, do we have any questions on your screen?
Hello,
No.
sorry. No, we haven't had anything come through just yet. Lots of people coming through with positive comments and saying how much they've enjoyed the talk, but nothing specific at the moment.
Well, you can always just read out the positive comments.
Well, we've got plenty of positive comments, but could I just ask one thing, Michael, which I think you probably explained very clearly, and perhaps I slightly missed it, and that is the sort of multifactorial aspects of deprivation. Could you just clarify one thing for me, and that is the BAME Society, housing, and all the other factors, the question of comorbidity. I mean, can you put a weighting on it? I mean, is there any indication that one of these factors is more important and out trumps another factor, or do we have to have, or is it a synchronous approach?
It's a good question, and I've not been able to do it. It would be nice to have a big model and say it's this one, but there's a kind of path dependency. So invest in early childhood, and a lot of other good things follow. Children are ready for school. If you've invested in early childhood, children who are ready for school will do better in school. And if they do better in school, they're more likely to get qualifications, get a better job, a higher income, live in a nicer neighborhood, and better health. Now that doesn't, so I think it does start with early life, but it doesn't mean that it's all over by age 5 and there's nothing you can do. We know that social isolation kills older people. So for older people, a priority is to stay socially engaged. And that's the priority. And it'll make a difference to older people's lives. For working age people, having enough money to feed their children is of vital importance, and having meaningful life. So your question's a good one, but I think it's too difficult to give a precise answer because we think that action's needed through the life course, and you can enter at different phases of the life course.
Yeah, that seems very logical. There is another question here. I would be grateful if people who put questions on the chat line could also put their own names so I can so that we can identify who's actually asked the question. There's one here. Can you explain the reduction in the rate of improvement in life expectancy in UK, Iceland, and USA, because they are already there and the rest are still catching up? That was a question, Michael. I'm not sure.
Well, let me take the US first. The US start because it was the bottom of the heap. The life expectancy in the US started to fall behind the other rich countries around the time Reagan became president in 1980. And you can see the slowdown. So the other rich countries continued improvement in life expectancy, and the US lagged behind. We did a study that got a lot of publicity, particularly in the US, not so much publicity in the UK, comparing health in middle-aged English and Americans, and showing the Americans were sicker at age 55 to 64. So already in the 1990s, in the US, and then Anne Case and Angus Deaton again got huge notice for publishing a simple paper that they called Deaths of Despair, and showing that in the US, for white men and women, middle age, there was a rise in mortality that was largely because of drugs, opioid poisonings, suicide, and alcohol. And they called it Deaths of Despair. And they published a book last year with that name, Deaths of Despair. And they showed, well, the original data showed a gradient. The fewer years of education, the higher the mortality. And they focused on what they called working class, I mean, people without a 4-year college degree. And that's where there was this steep rise in mortality. So in a way, it's not more mysterious what was going on. In Britain, happily, we didn't have these deaths of despair. We didn't have opioid poisonings to anything like the degree they had in the US. But we see elements of it in Scotland as well, and some rise in mortality at the same middle ages in England. So I think what we're saying is the possibility of people to lead meaningful lives was made harder by the kinds of influences I was talking about, the failure of salaries to rise, the problems with neighborhood, the difficulty of affording nutritious food, and the like.
Yeah, there's a whole load of questions have appeared, Michael. So the next one is from Ian Martin. It has been stated in the media that the rate and severity of COVID in the BAME community, who are healthcare professionals, is greater. How is this explained, assuming that comparative professions presumably have the same level of deprivation or wealth?
Yeah, this one has really troubled me. I don't know the answer. I don't know the answer to that question because whereas the ONS data show very clearly that most of the excess in the BAME communities can be attributed to deprivation, that clearly doesn't apply to doctors. So I don't know the answer. Chan Nagpal, the chair of council, the British Medical Association, he speculated, but I don't know if it's true, but he speculated that doctors from ethnic minorities might be more likely to be exposed at work. They may be a bit less forthcoming in demanding access to PPE and the kind of jobs related to exposure. I don't know. That's the explanation. Whether it's going home to multi-generational crowded households, I don't. So having said 3 times, I don't know the answer, but it's an excellent question and it troubles me.
Well, thank you. This is another question from George Naismith. From the data that you have shown, what policies would be most appropriate for government to adopt to ameliorate the current trends related to inequality? Is it housing, or is it support for dietary health, or is it something else?
It's the 5 domains that I discussed. Tomorrow, the government could take action. One of my records, take early life, give every child the best start in life. We said that child poverty should be 10%, which is the level it is in the Nordic countries and South Korea, not over 20%, which is the level it is now. That could be changed through the fiscal system. We've got a terribly repressive benefit system, which is totally inadequate, and a taxation system, I didn't show you, that's regressive. It's not progressive at all. People in the highest level of income pay about the same rate of tax as people at the bottom, because we shifted from direct to indirect taxation and property tax, council tax. So reducing child poverty should be a priority. Reopening the 1,000 Sure Start children's centres that closed over the last decade could make a real difference. Education. It's hard not to be upset. I saw a figure, and I can't verify it independently, but I saw a figure that the amount of money we spent on Eat Out to Help Out was it was around, in fact, I'll look it up because I made a copy of it. I made a copy of the figure. It was so dramatic. The Eat Out to Help Out cost £849 million. For £849 million, you could buy all 1.4 million children eligible for free school meals, a £400 Chromebook computer, and 12 months of a £20 a month broadband for the same amount of money. Now, I think that might have been a better investment than Eat Out to Help Out, which helped spread the virus. Instead, we could have been making arrangements so children in school now wouldn't be, oh my God, they went back to school for one day, then closed down the schools, and back in the same terrible situation that if you're from a poor family, you can't get access in the way you can from a rich family. Third, look at the gig economy. Look at employment. So in other words, to your question, I made very tangible, practical recommendations across 5 domains of things we can start doing right now. So looking at the nature of employment, one of the things I would do is pay every care worker a living wage. Half the care workers in adult social care don't get a living wage. I'd pay every care worker a living wage. I would start right now to establish proper career progression for workers in adult social care. Vitally important. I would be trying to deal with the housing crisis. You can't solve that tomorrow, but you can start tomorrow to work on that. I was asked by the BBC, what would you do about the high mortality in Black, Asian and minority ethnic groups? A senior politician said they should wear masks, wash their hands and practice social distancing. And I said, good advice. And I would deal with structural racism. But when would you start doing that? What are you going to do tomorrow? Tomorrow, I would start dealing with structural racism. So I think there's a great deal we can start doing right now. And I laid out these specific concrete actions.
Michael, thanks very much. That's a very comprehensive answer. There's another question that I suppose related from John Rennie. These findings are political dynamite, especially the change in expectation of life after 2010 and the change of government. Are these issues resolved by a fairer benefit system? I suspect you've answered most of that, but have you anything to add to it, John?
I mean, I would say very clearly, every single employed person should have a living wage. Not when George Osborne changed the language and there was a living wage and he talked about the national living wage, which was not a living wage. It was not enough to live on. But every employed person should have a living wage, and we should be encouraging employment for as many people as possible. Much better to be in employment than on benefits, no question about it. And everyone in employment should have the living wage. For those who can't work, the benefit system needs to be more generous than it is, and a good deal less punitive than it is.
Thank you. One from Graham Layer. Are you expecting any differences in acceptance of the COVID vaccines between the various deprivation sections of society, comparing low to high, and thus ending up with worse outcomes in some groups? which is an interesting question.
It's an interesting question. I don't have figures on vaccine hesitancy by socioeconomic or ethnic group. I don't know the figures. I had a conversation with some officials in the Department of Health and Social Care on Monday, this week, about precisely this question. And I said I'm happy to help in any way I can to make sure the rollout does reach otherwise hard to reach groups. So the question of vaccine hesitancy is an important one. And I don't know if there are figures for that, but that's why the medical profession is so important in giving a lead.
Okay, well, Clive Quick asks, have you received any comments on your latest report from the current Labour Party?
Yes, I have. They've beaten a path to my door. They would like me to talk to them. I'd like to talk to the government as well. So I didn't say no to the Labour Party. No, I only want to talk to the government. I said, I'm happy to talk to them and I'm happy to talk to the government. But the Labour Party has approached me and asked, would I talk to them? The government has been a bit silent.
Yeah, Hugh Rogers asks a very similar question. Are any of the political parties hearing your conclusions? I guess you've probably answered that one.
Yeah, well, from the approach from Labour, I think they are. And I was at a seminar that Norman Lamb from the Lib Dems was involved in, and they're clearly listening. I haven't spoken, so I've talked to the Lib Dems before, I've talked to Labour before, and previously I had talked to government, but not in 2020. And in fact, in the early years of the Conservative government, I did talk to them a bit, and I had a meeting with the Labour Party leaders in the early years of the Conservative-led coalition government. And the Labour Party leaders said to me, we will use your report to beat the government round the head with, but you have to talk to the government. You can't sit on your hands and wait till there's a change of government. And so they were very statesmanlike. They said, we expect you to talk to the government of the day. And I'd like to do that. I'm very happy to do that. I'd like them to take it seriously. When we published our report in February, I said, if the Prime Minister is serious about levelling up, we've given him the evidence he can use. We've made the recommendations on which he can base his levelling up strategy. So I signalled my willingness, and we're working with Greater Manchester. At the launch of our February report, Andy Burnham spoke at the launch, the Mayor of Greater Manchester, and he said, I stand ready to work with the national government. We don't want to make this either or. I'd like to work with the national government, I'd like to work with the opposition, and I am working with local and regional government.
Thanks. Well, we've just got two final questions. The first is from Nicholas Madden. Regarding UK's poor rate of increase of life expectancy, how does actual age of life expectancy relate to the rate of increase of life expectancy in individual countries?
I don't quite understand the question.
I'm not quite.
The life table approach takes that into account. So you can get life expectancy at different ages, and the life table approach does take that into account. So it's not related to age distribution. And when I showed you the excess mortality, that was age standardized, the excess mortality in time of COVID, that was age standardized. And just a question you didn't ask me, but it relates to one that you did. After I chaired the WHO Commission on Social Determinants of Health, we reported in 2008, we did a commission for the European region, we did one on social determinants for the Americas, and I'm now working in the Eastern Mediterranean region of WHO, North Africa, and the Middle East. And they were very conscious. We had an online meeting of our commissioners in December, just after we launched the Build Back Fairer report. And they said, we would like our report, which we're due to publish in March next year, we'd like it to be called Build Back Fairer. So in other words, related to the question of, is the government listening? We want governments in other countries to listen. And the whole idea that we should not go back to the status quo, but we should think about how to build back fairer has resonance well beyond this country.
Yeah, Michael, there's a whole load of other questions come up. I don't want to, I mean, you've been really very, very good, and it's been fascinating, but we don't want to take up too much of your time. But can you take another 2 questions?
Sure.
Would that be okay? You sure?
Yep. Yeah.
To what, this is from Alistair Sterling, to what degree is the decrease in life expectancy due to diseases of excess? And is there a socioeconomic gradient to this?
Well, there's very much a socioeconomic gradient. As I showed you very clearly, the gradient in life expectancy is very clear, steeper in the north of the country than in the southeast. And in fact, as I showed you, for the bottom 10%, it's actually going down. So there's a clear social gradient. The less the deprivation, the greater the increase. The greater the deprivation, the smaller the increase, or even a decline. I don't find it helpful to talk about diseases of excess, because all of the major killing diseases, almost all, increase in frequency with deprivation. They're actually diseases not of excess, but of deprivation. Now, if by excess you mean, overweight and obesity, yeah, okay, you can call that excess. I call that a deficiency of a good diet, that deficiency of the conditions to lead a decent life. So the major diseases we're talking about tend to be more frequent as you go down the social hierarchy. So I think diseases of excess is not a terribly helpful way to think about them.
Fine. I think there's a very, very last question, Michael, from Meena Agrawal. The rapid increase in our population must be contributing significantly to the economic and social and housing issues. What do you think would be a way forward to deal with this problem? That's a major question to come through at the very end, Michael. But...
Well, the rapid increase in our population, I mean, I'm not an expert on this, but the economists I trust tell me that migration is a net plus for the economy. So to the extent that our growth in the economy is due to migration, it's been a net plus economically. Now, it's caused social problems. It was exploited for the Brexit argument. But as we know, I don't want to get into this, but he says, getting into it, as we know, the smaller the immigrant population of an area, the more likely people were to vote Brexit. The larger the immigrant population, the more likely people were to vote Remain. So there was a lot of prejudice about migrants, but it was more about migrants living somewhere else, not living next door. And their migration is a net plus to the economy. So these islands are crowded, no question about it, but I don't think that by itself is a cause of our problems. Hong Kong's a pretty crowded place, and it's got the longest life expectancy in the world. Japan's a pretty crowded place. 2/3 of it's uninhabited, but the inhabited parts are incredibly crowded. And it, before Hong Kong beat it, had the longest life expectancy in the world. So I don't think the population size or the density is terribly important for health. I think prejudice and racism is pretty bad. I think it's pretty bad, obviously, for the people who are subjected to racism. But I think it's pretty bad for all of us. Living in a society where racism is widespread is not a very nice society in which to live. And among the many sins of the soon-to-be departed President of the United States was his fostering of racism, fostering of white supremacy. And look what Georgia's just done to him. Georgia has just elected its first ever Black senator, the first Southern Democrat to be elected to the United States Senate. It's almost saying, you racist, look what we're going to do to spite you. We're going to elect a Black senator. I happen to have met the Reverend Warnock when our Commission on Equity and Health and Equalities in the Americas held a meeting in Atlanta. We went to visit the Ebenezer Baptist Church in Atlanta, Martin Luther King's church, of which the Reverend Warnock is the pastor. And he was absolutely inspiring of what he was doing. Maybe he was driven by religion, but he was a community activist of what he was doing to improve the life of his community. And if I can just say one thing, forgive me for going off on this rant, but he had a program on weekends. One of the problems with Black youths in the US is the police arrest them for no reason, no good reason, and then they have a record. And once they've got a record of having been arrested, that's it for the rest of their lives, trying to get a job. He had a program for kids who'd been arrested but not charged to expunge the record of the arrest, to improve the life chances of young Black kids in Atlanta. Well, this man's just been elected to the United States Senate. I mean, he's a leader, and it's inspiring. So I think, to come back to the question, I'm sorry to go off on this rant. I don't think the problem that we have is too many people. I think the problem we have is not putting fairness, equity, justice at the heart of everything we do.
Michael, thank you very, very much indeed. I'm afraid we're going to have to end now. We could go on for a lot longer, but time has caught up with us. Michael, you really have provided us with a most tremendous and fascinating talk. And it's my pleasure on behalf of the Society to thank you most sincerely for taking this time to speak to us. I can assure you we're extremely grateful. I think we've been privileged to hear from a world authority on a hugely important, albeit inconvenient and uncomfortable societal topic. And I think many of us will take most of your messages away and think deeply and clearly about the implications. I really do thank you most sincerely, Michael, and I'm sorry that we kept you longer than I had anticipated, but the questions came thick and fast, which is an indication of how much we appreciated what you had to say. So thank you so much, Michael. We're very, very grateful. The last thing I have to do is to really remind fellas of the next webinar, which will be on February the 10th, on 5 o'clock on February the 10th, when Steve Heyer will be taking us through the story of Harold Shipman. So that brings us to the end of this webinar. Thanks all for attending. Have a good evening, keep well, and keep safe. Goodbye.
Thank you. Bye-bye.
Thanks, Michael.